So welcome to NUR203 Pediatric Nursing. I am Professor Bogart. I am also the lead pediatric professor. So any problems, you come to me, but if you can't get me, who do you go to? Go to Dr. Brown. And I encourage you to. I don't get in trouble for you going to Dr. Brown. It's not going to make me not like you or any of that thing that you might think. I don't do those things, all right? If I don't give you what you need, please go to Dr. Brown, all right? And we have a great working relationship together. So I've been in Fortis a long time, since 2017. I have done ground, I have done clinicals, I've done sims, and I have also now been, since we started pediatric online in 2020, right before COVID, actually right as COVID was going, we opened the pediatric online program. So if you need anything about anything, I can probably direct you in the right way, because I understand Fortis and the way it works, all right? How is my class going to run? Well, I will give an announcement, and I'll tell you what's due. This week is only a discussion question. And I know probably the first question is, can you answer the discussion question when you do the original post? Isn't that a great question, right? And I'm going to tell you, you can, if there's enough to answer another student with, okay? But if there's one person, it's really not, giving you any information. These discussion questions, yes, they are a lot of work. Yes, they're time consuming, but I want you to know there are HESI questions that come from it and exam questions. Especially go back and look at anything I write as a comment. I will always put a comment in your discussion questions of something you should know, a little bit more information. You might see something, okay? So tonight, every night, we'll do a PowerPoint first. When we're done, we will do a Kahoots. I'm working on doing Kahoots after each PowerPoint. Next week is already set, so we'll be doing that. Instead of doing at the end of a whole class, doing, for instance, next week is infants, toddlers, and preschoolers. I'm going to be doing two Kahoots. One with infants, because it's a lot of change in that first year of life. And then the second one is going to be toddlers and preschoolers, because they're sort of similar. And this actually shows you those differences that you need to know. Now, this week, we're going to be doing just a quick introduction PowerPoint. If you just came from community, you've gotten the information. I'm going to hit that stuff, which is very important, so you know and we're on the same page. And basically, that page is communicate with me. Something's going on your end. You can't complete an assignment, or you're not well enough to take an exam. Please communicate with me. I can work with you before something is due, before an exam. When it's already done, already due, I can't help you. So what is the bottom line? Please communicate with me. So let's start out with our PowerPoint on the orientation to online nursing. And we're also going to be doing our regular PowerPoint. It's just basically a big overview this week. And then we're going to be doing a Kahoots, which hit those concepts you might see on your quiz next week, okay? Quizzes are be given at the beginning of class and on the week before's material. So next week when you come in, everything you heard tonight is going to be a 10-question quiz. All right? Don't overthink it. All right? There are 6 chapters. Don't overthink it. All right? Go back to the Kahoots, look at the concepts that are always hit. That's where you're going to see those questions come from. Okay? So let's go ahead. Now, we all have different looking slideshows. We all do different things with them, but they all say basically the same thing. So online nursing is online teaching is you've got to basically come to class and be prepared, and you have to use your technology. One thing I expect is that you have either a computer charged or it's charged into the wall for class, for quizzes, for exams. Please take good care of your equipment and have it ready. I've had students in the middle of exams say, my battery's just about to die. And they like zip through the exam and don't do well and then want me to do something. I can't. So please make sure that you come prepared, which is your equipment in working order. Now, we'll be meeting once a week. We'll be meeting on Tuesday at 8 p.m. Eastern Time. So I've already basically discussed that. Something that's going on, you don't know what it is, or you need help, there's several ways you can get a hold of me. Well, if it's something that can wait, just send me a message on Canvas or an email, whichever you like. Both are good. I'm always checking on my phone if anybody is messaging me. And I do that all the time. I think it's part of my OCD nature or something. I don't know. So the other way you can get a hold of me is through my regular cell phone. That's for something that's emergent, something that you're sitting down right now, you have the time to do something, you don't know how to do it or what to do, and it has to be done now because your schedules are so full right now. Send me a text or call me on my phone, all right? A text is actually better. I get a lot of spam stuff, so do me a text and I can call you right back, okay? Now, can't get a hold of me. I've already told you, get a hold of Dr. Brown. You must use these numbers here and this email address. It is not D Brown like most of the email addresses. It's Darlene.Brown. There is another D.Brown in the Fortis system, believe it or not. And use that phone. It is the school phone. She answers it at all hours of the night and day. If she doesn't, it's because she's on a meeting. And that's the only time she doesn't answer it. Again, just simple etiquette, right? I'm nice to you, you be nice to me. Don't give me big capital letters because you're really upset. You know, I understand you're stressed. I get that. I want to help. I'm here to make every single student in this classroom pass, succeed in this course. And the way you do it is by talking with me and talking not at me, okay? Make sure you get here on time. 8 o'clock is on time, 8:01 is 15 minutes late. You leave early, it's also by 15-minute increments. We've already discussed the discussion boards. You can put them in. Just make sure you get your original in by Wednesday, and then the rest, if you want to do it right away, okay? As long as there's enough there for you to do it with. Remember, your syllabus is the Bible. What it says and what's due that week, it is there, okay? So if you have a question about when something's due, go back to the syllabus, and it's right in your Canvas shell. Okay, academic integrity is a big issue. Academic integrity is where you do something that you're cheating, whether it's through quizzes, exams, through papers. That means you're doing work that's not your own and you're copying it. I highly suggest you do not. They're doing a lot of different things to look for this teaching, altering assignments, et cetera, et cetera. Do your own work. You can use somebody else's work, but don't copy word for word. You need to change it up. You need to make it your own and your own language, okay? Excuse me. That also is telling me you understand it because you had to change those words. Another thing is knowing that nursing is a great profession and we must maintain that, you know, ethic, morality, and keep it as pure and wonderful as it really is, and keep it on that professional level. There are quite a few cheat sites on the internet, and we find more and more every day. These on the bottom one here are just some of them. And let me tell you, for this, there is a cheat team, or I don't know, person who looks for academic integrity. They're always looking at these websites because we are, you know, you're becoming nurses and we are, and you will be, and still are professionals. So, you know, let's just do our own work. All right. Now, turning in assignments, unless I don't hear from you, your assignment is due on Sunday of that week assigned, which means the discussion question is due by Sunday, 11:59. Now, if you don't turn it in and haven't called me, and it's now day number 8, it will have a minus 10% deduction, and you have one more week to turn it in. If during that week you decide, oh, wait, this is going on, I may not get it in again, whatever assignment, let me know. This is what's going in my life. And then I will ask you anything that goes on and you have the ability to get documentation, get that documentation. I didn't take that exam because I was rushed to the ER. Give me our ER paper. It shows me you were rushed. You couldn't take it. Whatever you see, whatever you can do. Attendance is the live sessions, but the other way that it's looked at is the way you are entering your work in Canvas. So if you look at all the assignments set up, there are going to be 2 times you have to enter the Canvas shell minimum. That's at least the discussion questions, right? Those are what you need as basically stamps that say, I have attendance in the shell. And of course, the other one is you being here on camera, the whole face, not leaning off, not dark, not a ceiling fan, and not out the window. I want to see you. And that's for when you're here on camera with me during class. They do spot checks to make sure that you have been on. And a lot of the accrediting people that come in go and will look to check stuff like that. If you are not on camera or you are in a car, whether driving it or a passenger backseat, doesn't matter. I will tell you, number one, please turn on your camera, or please, are you in a car? You need to stop. You need to be out of the car. There is a lot of problems with legalities, you being in the car, being in class, and we do not want that. We will tell you first if you are not on camera, and I'll do it one more time. And if not, I will remove you from the class. So just be aware that if you're getting messages, please look. It could be me saying, hey, I'm trying to help you. Please come back on camera. Know that 1 minute is 15 minutes late. So be aware, knowing that you will be getting letters at the 5, 10, and 15 and 20% to let you know you're getting close. 2 classes missed is going to be 20%. And be careful, those little short ones that you do, those 30 minutes, 45 minutes that you leave late, leave early, or come in late, be careful, they add up quickly. So if you're getting up to that mark, be aware. Also, if you're late, why were you late? Is it something you can document with? Okay, that's what we want to see. Give me documentation, I can help. Know that if it's 20%, they will take you down a whole letter grade. So anything that can help us not do that is you remembering to get documentation. How to be successful? Do your work and talk to me, and do it on time, right? The way they have this course set up is doing these different sort of the old CJ Sims, they were due when that type of topic was due. And especially during this one, you're going to see a respiratory assessment during the week that we're doing it. We're going to have a GI assessment during the week that we're doing it. So do it when they say and when they're due, because it does help you with that understanding. I already told you how to be successful. Talk to me. Know that when you come in, you still have to do all of those things to get to the week 1. Some of you have done it, some haven't yet. I've looked at that. So make sure you go through the modules and do it. Come to class, listen, and then let's say you're having troubles during the quiz. There's a thunderstorm. You're all of a sudden your computer shut off, or you ran out of whatever happens. Something happens, let me know immediately. The quizzes and exams, I can check every time you click a button. So I know if you sent me a message that you immediately got off the exam, if that's what the problem was and you couldn't continue, and you sent me that message right away, I could put those times together and say, okay, this did happen. There's the times they do match, and then I can let you finish that exam if that's what's going on. Okay. Be aware I can help if I know what's going on. I do tutoring and I work on your time. I don't say it's this hour on this day because most of the time you don't make that. If you need help, let me know. I'll work in your schedule to give you the time you need. And I promise I'm not going to keep you here for 2 hours. That's ridiculous. 15, 20 minutes, you can get what you need and go because you are not going to hear more than that because you are too busy. You want an answer to a question. You want to know how to help yourself. I guide you quickly. Okay. And that's part of all the tutoring, etc. We know that there is an 80-20 split on this class, which means 80% are the key graded assignments. You need exams, quizzes, and your essay. The other part is all, quote, that busy work, all that homework, all right? So make sure you have a 78 in your KGA. Then we add on your homework. I highly suggest when you're doing your homework assignments that you get a minimum of a 78 when you turn that grade in. Then you know your homework are not going to fail you. Do you realize every term there are more than one student who fail because of homework and did well on their KGA? Don't do that to yourself, okay? Just a hint again. Homework grades are turned off, and on week 6, we turn them back on. And we do that to show you how those homework will affect your grade entirety, okay? And then on week 8, it's turned off all the way until all of the HESI and remediation is in, and that is your final grade. I only use one device for a quiz. I use 2 devices for an exam. And again, please get that charger, make sure it's charged. And again, keep face on camera. During exams especially, I see faces start to go off camera like that. Don't do it. I will let you know, and I can remove you, and I can give you a 0. My job is not to do that. I don't want to. So make sure that you stay on the camera. I already said that the quizzes are 10 questions, 15 minutes at the beginning of the class on camera. And quizzes cannot be made up for any reason. But I will tell you, let's say you were in the hospital ER because of whatever, and you couldn't take that quiz, and that quiz will have you pass. Well, do you have the documentation? Did you remember to get it? Or do you have to go back and find it? So if you can't do something, you can give me documentation, get it then and there. You could possibly be able to take that quiz with Dr. Brown through an appeal. Exams. Make sure you do the exam soft practice exam. The reason. The first exam, if it comes up and something happens, you can't get on, etc., if you've done the practice exam, they're going to work with you better in order to retake it, whatever needs to be done. So again, do the practice. Exams are one attempt, but if it's one of those things, technical's going on, you had a blackout on your screen. I've seen that happen to my students before. Again, stop, tell me, I'll verify times, and I can have you restart the exam at another time from the place that you left off. I can do that, okay? If you're going to miss an exam, you have to let me know before. After the exam is started and going and you're not there, you're going to get a minus 10% deduction. So before exam, and this has happened several times to me, student had a massive migraine, and you could see her eyes, her forehead, you could see she was miserable. Right before the exam, I said, no, you're not taking it. You can go back another day. And they agreed, and thank you so much. All right? Tell me. If you know way before that, let me know. If you go to the ER because you're sick, doctor, just let me know. There are some campuses that like to do their exams on campus. And that's okay. The student must let me know, 1 or 5 of you, whatever it is. Also, who's ever proctoring on the campus need to message me. So when both of those are done, I will send that person the access code, and then you can take your exam on campus at the same time as the other students, or as closely to it as possible. But you still have to come back for class. You will have class starting at 9:30 on the days of exam. So it's almost an hour there that we get, and you will be getting information. You know about exams. We check everything, or your surroundings, et cetera, et cetera. We know that exams, if you miss them, don't tell me. Number one, you're going to get a 0 on the exam book, on the grade book. And number two, if you want to retake it, again, it will be a minus 10%. We've already said that 3 times. Exams and quizzes are through Canvas, and I have an access code. You can't open them till I tell you. Again, anything happens, let me know, and I can let you retake it, whatever I have to do. Specialty HESI exams. Know that it is 20% of your grade, and it's 1 attempt only. I've got great HESI review material, okay? I do a HESI Q&A review on the Saturday before. I also have HESI Cahoots I give you that are extremely helpful. Of course, there's remediation. I'll send that to you again. Make sure you have your ID. That's something that's forgotten. How many times did you hear about contact your instructor here, right? Homework assignments are due, as they're said in the syllabus, due by that Sunday night. If not, you got another week to do it. NCLEX questions. Be careful. Do whatever they tell you the areas to do it in. The first discussion question, everybody thinks it's just tell me about you. There's a second part. It's all about nutrition, infant nutrition, children nutrition. Make sure you answer both parts. That's always forgotten. And about 5 to 10 students in each class. When you put the NCLEX questions, make sure you submit them in the proper format. If you don't know what that is, I can send you a little directions. Let me know. If you've already sent something in and it's not what should be there, I will say a 0 in the grade book. Doesn't mean you're going to keep a 0, but a 0 in the grade book, and I will send you that information on how to submit it correctly. And again, make sure you get at least that 78. You can do it over and over again all you want. At the end, there's a HESI assignment and a practice exams. They're on week 8 and week 10. There's like 60, 70 questions each. So it is quite cumbersome, but it just covers a little bit of everything. Between that and my HESI reviews, I mean, you guys, when you look at the average HESI score in pediatrics, they're 900 and above if you do what I tell you to do, okay? Know that these screenshots that sometimes you used to do, we don't like screenshots. We can go back in and look for things. So just to know that it has to be through the shell. CJ Sims is not here anymore, and we're doing the other one. We're doing all of these new case studies. It's actually quite good what we've done, and we're doing them in an order that goes through all of the things, just like you would do your NCLEX questions, and it pops up and you do them and you submit, or the case studies, the HESI assignment, and your practice exams, it will come up the same way. Now, pediatrics has a paper. It's a little project. It's 3 parts to it. Now, think of a diagnosis that could be a pediatric diagnosis, something that you're interested in, something that you had, your daughter had, your uncle, your best friend's kid, whatever. You want to know more about it. So make it interesting. Give me a 250-word APA paper and describe it. What is it? If you're going to talk about asthma, tell me what asthma is. The second portion is an assessment. That form is on your modules, and it's a lot of papers, but it's mostly circle. The assessment is, what would that assessment look like for, let's say, with a child with asthma? So your respiratory would not be clear, clear, clear. It would be expiratory wheezing, retractions, nasal flaring, tachypnea, something like that, right? Make it to that. And then the second portion, probably the last 3 pages are the most important. It goes into the theorists that it would be involved in your child and how you approach the child because of this theorist and what they say. And it also has to give 2 NANDA nursing diagnoses. Remember, related to, as evidenced by. If you send this stuff in early, I will grade it, send it back to you. And if you want a better grade, correct it, send it back to me. And you could do it piece by piece, okay? And every single diagnosis must be approved by me. I don't want 20 asthmas. Give me a little bit of everything, okay? There is a rubric there. We know with APA, we're going to be using scholarly information. And this is all about the way that you think about nursing and education, because they are the same thing. It's like, are you ready to go into that patient and take care of them? You do have all the equipment. You're going to go in for the HESI. Have you done everything to get ready? Have you studied that equipment? And that's what all of those things are discussing. And then just to give you something from a previous student who did 1145 on the HESI. She said as she was going through the course, she would really go and look, like the CJ Sims that are now replaced with the case studies. They're amazing. They're really good. Really go down into it. It's really understandable too. Go through them, understand them. If you don't, look it up, okay? And clicks questions the same way, so that you're really looking at those topics, those concepts, and understanding more. So I put it there just to show you what a student told me. It's not me telling you. Any questions? What was the key concept you have to understand about coming to pediatrics? What do you need to be successful? Anybody? Communication. Talk to me. Okay? If you don't know something, ask. And I'm going to tell you something, because it's something I live by. There are no stupid questions if you don't know the answer. Furthermore, if you don't know the answer, somebody else doesn't know it either, but are too shy, too afraid to ask. Okay? So at any point during lecture, cahoots, anything you don't understand, I want you to say, "Oh, Professor Bogart, I have a question." And I will stop and I'll answer it. I don't get upset. It doesn't bother me. In fact, I please ask me questions. All right, let's go on to our PowerPoint for today. So there's a lot of chapters, and you're looking at, oh my goodness, chapters 26, 27, 28, 29, 30. There's 5 chapters out there. How am I going to know it all? A lot of this is just an introduction. For instance, healthcare, healthy people. Why is it here? Well, it's just to let you know that all disparities, they look at them, whether the elderly, homeless, in poverty, children, they are a disparity. They're something that needs a little extra help, right? So the government back in the 1990s, I think, started it, where they look at certain things in the population, whether it's nutrition, whether it's weight, whether it's, physical activity, and they do programs to enhance that. And all this is to better the health of our children. Now, are any of you going to go on in your education for your BSN, your ARNP masters? And if you are, yes, this is the place where you go get information for a paper that you might have to do. Healthy people is, and it's got a lot of stuff in it, and you can always find a topic for a paper here. Children health problems, obesity and type 2 diabetes. Why are those put together? Well, it has been shown that children, like school aged, who are obese, have a higher incidence of becoming type 2 diabetic. That's what that means. Childhood injuries, why? Well, they're falling out of trees. They're doing things they shouldn't because they don't know rights and wrongs. Some are too young to know. Violence, between children always happens. Uh, Vaping, something newer. And yes, children do have mental health problems. I've seen it from simple depression to manic depressive schizophrenia in children. And I'm talking children ages 6, 7. I'm talking very young. Infant mortality. Now, the United States is a beautiful country, but we are very high on infant mortality. There's many other countries who have less infant death. And it's usually because they are that small premature baby. That's usually where we see, a lot of it. And I know that even in my career, the changes in the way that we do things have changed drastically. And all of it is to increase the life and to prevent, premature death because of things like low birth weight. Childhood mortality, why? Well, they're into everything. Unintentional injuries is what the big word for childhood mortality. Unintentional. Well, it could be injuries. They could have a gun. They don't know that the safety's not on, or daddy forgot to unload the bullet. Kids like to play with things. That happens. And then as we get into the adolescence, you're going to see that one of the things is that they're concerned about body image. And sometimes you don't look the way you should, or feel like you don't look the way you should. Too fat, too skinny, too many pimples. I wanted blue eyes. I got brown eyes, whatever it is. And because of that lack of self esteem, because of body image, you'll see a high incidence of suicide in adolescents. But the injuries due to firearms exceeds that in that area, those age children. Another group that we see is, and I've mentioned some of them, homelessness, poverty, low birth weight, chronic illnesses. What would be a chronic illness? Cystic fibrosis, sickle cell, all of these things can cause you to die if you're not taking care of them properly, right? And then foreign born, what genetics do we have there? They have diseases we don't know about. And then why would children in daycare centers be an increase in childhood morbidity or mortality? Why do they die? Daycare centers. Think about, what do the kids do all day long? They play with toys. What do they do
Choking.
with the toys? They put it in their
Mm.
mouth and they swap spit all day long, from germ to germ to germ to germ. Now, is that a bad thing? Not really. Not really. Why do I say that? Because by the time they get to school, kindergarten, they already got all of these defenses and antibodies against those diseases, don't they? Now, we don't like when it COVID, that's like a completely different thing. But the normal stuff, the upper respiratories, the respiratory, the nasal congestion, all of those things get passed around and around. Pediatric nursing. One of the reasons why many nurses don't go into pediatric nursing is they have parents. And many nurses don't want to deal with the parents. And I know that. I am one of those strange nurses. I'm an adult nurse. I'm also a pediatric nurse. And I've done about the same time in each, believe it or not. And what do I like better? I like them both. Probably my most favorite was the cardiac intensive care unit for children. I absolutely love taking care of congenital heart defects. The parents are really hard. Can you imagine not knowing your child has this congenital heart defect and may need 3 surgeries in the future, combined with how many cardiac caths, follow up with doctors, and la, 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 la. So those parents can be a little bit obsessive, and it's okay. All right? Because remember, this child, the center of their life, the only constant in their life is their family, their parents. Okay? Another thing that we're doing more of than we used to is what we call atraumatic care. You know, we used to give shots and we didn't care if it hurt or burned. We used to put IVs in and we didn't care if we numbed it or not. Hold still, let me hold that down, let me get it in. Oh, no, we don't do that anymore. We put them in a comfort holding position. We numb the areas. We distract them with noise and music and bubbles and, games and that iPad for that older kid. All of this stuff we do to reduce that psychological distress, minimize physical distress, and do no harm, right? These are what our goals are. So, pediatric nursing, you're that person between that child and that healthcare and the family. And it's where we're going to be doing the teaching, not just the parents. Children, young kids understand and they can help us take care of them. And we know parents need to be taught whatever about their child. And of course, injury prevention is huge. So we help them with all of this, deciding. Sometimes parents will ask you, well, should I do that surgery or not? They say it's not really needed. And now you're caught in the middle. So what do? Well, you offer them facts and information, not an opinion, right? That's the easiest way to go about it. And it's actually better for that parent. So, African American boys, ages 15 and 19, the leading cause of death. What did I say?
Firearms.
It is firearms. Thank you. Firearms. Suicide second. All right. Another thing we have to work about, and this I had a really hard time with because I am from an extremely small little town in country New York. There was no different cultures anywhere in that town. And I moved to Miami. I married a Cuban and now divorced him, married a Jamaican. So I'm multicultural at the present. And I love culture and I love people and I like things all about them and learning about them. When you are a nurse, you have to respect what they're doing, their religious beliefs, etc. You don't have to agree with it, okay? But you have to allow them the opportunity to practice whatever their things are, whatever their religion or whatever they call it. So, family, what is it? Well, there's lots of families, aren't they? There's all types. And what we say is a family is whatever they say it is. It could be a child and the grandparents, a child with foster parents. It could be 2 men, 2 women. It could be 2 men, two men, 2 women all together. It could be all different things. Doesn't matter. Whatever the family is whatever they say it is. And those are basically all the names of the things. Our communal families are our churches and our things that we belong to. We know that as we are talking with these family groups now, right? Because it's family-centered care, we have to include the family. We have to know who's going to be that spokesperson. Who am I going to direct my teaching towards? Is it the father? Is it the mother? Or is it the grandmother? Or is it the child? And again, it's opening your eyes. And if you can't figure it out, I ask. I have never had a family offended by me asking things about culture that I just didn't know. In fact, they told me they appreciated it. So if you don't know, you're going to ask. There's all sorts of parenting styles. We got the strict ones. We got the ones who, let them do whatever they want. Again, this is them. You have to minimize bad behavior when you are needed to do something with that child. Again, there's all sorts of different families, and just know that there could be different things that you don't even know about, maybe needs that you don't even know about. Again, you're going to be asking. So all different stuff. Well done. All right. Genetics. Genetics. How do we grow? Why am I tall and you're short? Why am I fat and you're skinny? Well, it's all because of this genetic things, right? So as we're growing, how do we develop? And I think this thing, interrelated, simultaneous, ongoing. That picture on the bottom is 6 months of an infant's life, from crawling to walking. Can you imagine an infant? And we're going to learn this next week, even more in depth. The first thing they do is they lift their head. And that's about 3 months old. And then at 1 year is when they're attempting to walk or walking. So they couldn't even lift their head up. So by 1 year, that interrelated, simultaneously ongoing, they're doing more and more and more and more. So there's different ways that we describe growth and development. Just knowing that sequential is just a sequence. That means I'm going to lift my head before I roll over. I'm going to roll over before I crawl. I'm going to crawl before I creep, and creep before I walk. It's a sequence of what you're going to do. Developmental pace is as they are developmentally aware and capable, they will do the next step of this sequence, okay? And those sensitive periods are those little different areas where they're more apt to be learning. They slow down and learning a little bit more in depth. Now, growth and development on children, and I put down here the word metabolism, but you all got a form that had vital signs on it. And I want you to know vital signs can be a little bit different in numbers, but what I want you to know that a newborn who is born, their initial heart rate is 140 to 160. As we get older, that heart rate comes lower and lower until the point when you're an adult and it's 60 to 100, right? Respiratory rate is the same thing. That's your metabolism. How fast does your heart have to be in order to keep up with the body's needs? We know thermoregulation at birth, they don't have much. Our goal is to get them nice and warm, put them on a warmer, wrap them up, put a hat on when they're born, because they don't regulate initially. We know sleep is important, rest, and then nutrition. Nutrition, nutrition, nutrition. If you don't feed the gas tank, you're not going to be able to go. If you don't fuel the brain, you're not going to be cognitively aware. You're not going to be doing those fine and gross motor skills that you should be doing. So nutrition is one of the things we're going to look at if this child is not turning over by 9 months. They should do that by 6. That's why we know those sort of things. We know that there's all sort of kids. We have, oh, my kid was so great, I want to have another one. You have the next kid, and they're the most difficult child. They're hard to feed. They're all gassy. They don't sleep at night. So again, there's all types of children, and to be aware, it's not all you. Now, I'm going to mention some of the theorists, but I'm not going to go into all of it today. Next week, we go into it more in depth. I'm going to start that mentioning it so that when we do it again next week, you're going to put some more pieces together. So Sigmund Freud, what he says, everything is about sex. Oral is an infant up to the point of adolescence. Think with their genitalia, right? The genital, that feeling of wanting warmth from another being. So Freud is all about sex, and there's different stages, and we'll go into why there are those stages. Erickson. Now, Erickson talks about the way a child um, associates with other people. So, for instance, trust versus mistrust. This is an infant who cries because they're hungry and want to be changed. And all of a sudden, mommy, daddy, aunt, Nana comes, picks the baby up, and takes care of their needs. That baby trusts me because I got my needs met. So, what is mistrust? That's that child who cries and cries and nobody comes. These are usually like in abusive homes, whether it's drug abuse, alcohol abuse, or homelessness, or many other things that can cause it, or just a mother who's going in, you know, uh, in depression where they can't deal with a child. So Erickson, how they deal with people. I want you to come. They came. I trust. And it goes on further, and we're going to go into what those mean. Piaget is about thinking. All of those words would drive me nuts. Piaget, thinking. For instance, at birth, a child does not know how to do anything. Initially, what do? Quote, we spank the butt, they take a deep breath, and they cry, right? So the first thing they do is they breathe. What's the next thing we do? We put something in their mouth, and all of a sudden they know, oh, they suck. That tastes good. Whether it's milk, whether it's breast, or whether it's a pacifier, right? So now they've learned how to do that. Give them a rattle. Initially, it's a reflex. They'll grab a hold of it. They didn't do it voluntarily yet. And then it's in their hand and they move. Oops, it made a noise. I like that. Next time they get the rattle, they'll take it and shake it because they know they like that sound. Again, thinking, building upon little pieces up to bigger pieces. Okay, and we're going to go into all those. The last one we're going to cover is Kohlberg. Again, look at all those words. What does it mean? Kohlberg talks about morality. What's that? Right and wrong and a consequence for either or. If I'm right, I'm going to get a good consequence. But if I'm bad, I'm going to get that timeout or whatever that punishment is. And usually the younger kids, that's all they understand, reward and punishment. Okay, play. What do kids do from the time they wake up, right? The older kids, they want to play. So we've named these plays different things. Whether socio-affective, we play with a bunch of people. Sense pleasure, oh, that's hands with sand and mush and mashed potatoes and, stuff that just gooey and it feels good. So it's about touch. Skill play, blocks on top of each other, Legos, right? Unoccupied play by himself. Dramatic or pretend play is used to describe situations. Usually that's something happened in a hospital or somewhere, and we can find out through play what happened. And of course, games work with kids. They love them. So, what does play do for these kids? Is there any benefit? Yes, there is. It's called sensorimotor development. What does that mean? Let's break up the word. Whenever you see a word you don't understand, pick out a piece that you may know. It'll work, right? Like cephalic, we know the cephala is a head. So anything with cephalic in it's going to be something about a head. Well, sensor motor, sense, touch, ori, mouth, motor, movement. So we are learning touch, put our mouth with stuff in it, and the movement and the sound it made. It's teaching us. It helps with that intelligence. Now you're learning. You're building on what you've learned. Piaget, right? Socialization. Now I picked up that rattle and I shook it, and mommy and Nana were giggling. Oh, look, they're shaking the rattle. That socialization. They can become creative. They're aware of surroundings, and these are great for children and toys. Now, besides that, we named the plays. What are the names? And knowing the names of the plays, how they play, is actually you can come into what the age group of these children are. Onlooker play. I'm looking at somebody else play. Solitary is alone. Now, the next three ones you need to know specifically. Parallel play, what is it? Well, it's a parallel. That means two lines next to each other, right? Well, here's one toddler, ages 1 to 3. Here's another toddler, and they're playing next to each other, parallel to each other. They're playing with their own toys. They're not sharing. Parallel play. As we get older into the preschoolers, now we play together, and that's associative play. 2 to 3 children playing together with no goal, they just play and play. Cooperative play, school age children. This is 2 or more children playing together, and there is a goal. Is it checkers? Somebody wins, or they're taking a Lego set and building a house. When they build a house, it's a goal, it's the end. Parallel toddler, associate is your preschooler, and cooperative is your school age. So because of toys, we can really help a child's their development. It's that pushing, the pulling, the rolling helps with the muscles, and it's also a great time, where parents can, even Nana, because I do too, helping children and making them come for you. Here's a toy, come get it, right? And you're getting the muscles strong. So assessing children, why do we assess children? Why do we need to know that they're doing certain things?
To meet
Well,
milestones.
yeah. And what happens if you don't meet milestones?
Developmental issues.
Right. How do we correct that?
Therapy.
Physical therapy, occupational therapy, speech therapy. And you know how we cure that the best? The quickest, the soonest we notify it. We see it, let's take care of it. Have you ever seen a child who's 2 and only speaks 2 words? They put them in therapy. 6 months later, you can't shut them up. It's happened to both of my older grandsons. It's amazing. So developmental assessments are done to make sure your child is where they need to be. And if not, to institute early intervention. Very good. We know that there are some things that will interfere with development, whether it's things like congenital malformations or a syndrome, Down syndrome, one thing you'd think of. So knowing that these things, you're going to have some delays. It's that maybe that nurse who identifies, maybe it's that parent or physician, again, identifying and getting them referred and getting them what they need as soon as we can. Early intervention. So communication. Well, first thing we talk about is HIPAA. You think of HIPAA and kids, why that? Well, their records are just as personal as adults, but you've got 18-year-olds now in your care. 18-year-olds, unless they're not cognitively aware. So if they're alert, oriented, they're cognitively aware, that 18-year-old child must give parents or guardian permission to look at their information. And if you give that information to the parents, you could be sued. It's a violation of HIPAA. This is the thing that's the hardest, I think. I worked in an ER, and very busy ER, trauma center. Nicholas, for those who know. Busy place. And there'll be kids 18 coming in, and you just got to be aware. Look at the age before you answer questions. Now, talking with families and parents can be hard. You have one parent who has detailed notes from birth, and the kid's now 6 years old, and you don't need to know all the details from birth. You need just a couple little things. So redirect and refocus that information and let them talk to you. Listen and be patient. And look at that cultural awareness. There are some cultures you shouldn't look them in the eye. You shouldn't touch them. You shouldn't invade their personal space. If you don't know, ask. Okay? I've found that out several different times. Several different cultures I had no clue about. If we are with a culture, a language we don't know, You cannot have the older sibling translate. It must be through an interpreter or that interpreter phone. Knowing that if you're going to communicate with children, you must be on their developmental level. All right. So what's the first thing you do if you're going to talk with a child? Where are they mentally, developmentally? What are they going to understand when I tell them? History taken. Again, identify who's going to be that person you're going to speak to. Is it the mother or is it the grandmother? Or the child was at the auntie's all weekend, so it might be the aunt that you might have to get that history from. And then chief complaint, so you don't get everything from birth, okay? And why are you here today? Birth history is important, especially with a child with more needs than a child who's never had, quote, a big birth history. And then, of course, their diet. What do they eat? You have some religions that are only vegetarians, or they don't eat this, or they don't eat that. And you have to respect that. Any previous surgeries, injuries, etc. Allergies are always important. And then any medications that they have gotten. Immunizations. Immunizations are important to know, number one, for yourself. This is a child in with upper respiratory infection. Have they been immunized with pertussis? Have they been immunized against influenza? Have they, so you know how to protect yourself and others. That helps with patient placement. You know, what room are you going to put that child in? Do they have to be in a private room? Immunizations are important. And then, of course, you look at any problems with growth development and then habits. Do they like that special blankie? Is that their comfort item from home? All right, very important to know these things. As we get older, sexual history is important. You're going to find out when we get to adolescence. You can have the parents leave and ask an adolescent to give information without a parent at the bedside if it's something affecting the care that they're there for that day. And again, that's family structure. Yes, who's the person you talk to? Anything in the family history that we should know about. If they're coming in with symptoms, let's say, of, urinating a lot and thirsty a lot. Well, is there any diabetes in your family? These are things you would like to know, or any medical history in your family. How do they adjust at school? I'll always ask a younger kid, so what's your favorite subject in school? So are you getting C's or B's? What are you doing? And they'll say, oh, I got 2 B's and an A. I'll go, oh, what a great job. Well, what they're telling you is they're adjusting to school and they're doing well. And that helps you with how do you communicate with them? Simple things like that, tricks that we do. Reviewing the body systems, forget head to toe in pediatrics. We don't do a head to toe. What we do is a focus. For instance, you have a baby or an older child in their mother's arms, quiet, comfortable, playing with a toy or whatever. That's the time to listen to the heart sounds and the breath sounds because they're quiet. They're not, that's what an infant does all the time, right? When they're awake. They're asleep. You don't hear anything but breath sounds and, the heart sounds. Again, what do they eat? Any cultural things? And then if there is, let's say that child who is a vegetarian, having a dietitian coming in, making sure they're getting enough nutrients in their food also. I don't know what is. You have an expert, call upon them. Again, assessment. Forget about that head to toe. It's not going to happen with a child. You do what you can when you can. And again, how do you do an assessment? You prepare it on the developmental age of the child. If it's a toddler, I'm going to go sit below them, get them comfortable, and then I'm going to get them comfortable by doing play. Ooh, where is your heart? Where's my heart? Well, let me listen to my heart. Let me listen to yours. And sometimes that's how you do your assessment. If the kid is going to go in a procedure that's going to hurt, be honest. It's going to hurt a little bit, but I'll do everything so it won't. Don't lie. Children never forget. They really don't. And again, doing it on the base on that child's age is great. So, which approach would be best to use to ensure a positive response from a toddler? Toddler, ages 1 to 3, the scariest of all the kids. They're scared of you more than any other age group. You're going to do what? You're going to go stand eye level or below them. I'm a big girl. I stand above a toddler. I look like I'm going to come down and hurt them. I'm going to sit below them. And then maybe a toddler, I give them a sticker, or I go, oh, what a cute little Spider-Man shirt you have on. How does Spider-Man shoots his web? And you'll see stuff like that. That kid's going to be calm, cool, collective, and you're going to get a great assessment then, aren't you? There's all sorts of growth charts. We know that that's all done. We do apical pulses up to the age of 5. It's recommended, okay? Know that blood pressure cuffs are all different sizes. It goes from extra large to 00, which fits on my little pinky, believe it or not. Lymph nodes in children. If you feel a lymph node, the kid's sick. If you feel a lymph node, you're sick. If there's nothing, you don't feel anything, the kid's good. When we're doing things, sometimes the easiest way is to look by an inspection only. Then you're going to auscultate and palpate those things. With a newborn infant, why do you think you do a rectal temp at birth? They teach you that in OB.
It's the most accurate.
It is. But isn't it to check there's an anus? Believe it or not, there are infants born, they don't have an anus, called an imperforated anus. There's no anus. Yes. So can you imagine that child's going to the surgery for a colostomy fairly quickly, aren't they? Again, other things is doing the neurological assessments. Kids love to hit their own knees and watch them pop in the air if you have to do stuff like that. Measuring things, head circumference, when would you do it? All of your infants, newborns, to make sure there's no water going on their brain. Their chest and the head, there is big correlation at birth. We'll go next week with that. And abdominal circumference, doing those, the infants before they feed, making sure that their food is going down, that they have a stable, steady abdominal circumference. Getting a proper weight on all children is extremely important on every single visit. They do that on children. When's the last time you had your weight done in an adult office? It's usually not done. It's done in the pediatric office. And the reason is because they have to give you medicine based on your weight now, not what it was a month ago. Another thing is getting the height on a child. Know that that little wooden thing coming down on that kid's head is scary. So you have to make it into a game. And I do. I'll put me underneath it and I'll pop it down. I go, oh, is it hitting now? Is that good? Okay, what's my number? Oh, let's see what your number is. Again, I'm playing with the kid to get what I need done. Blood pressure is going to be done anywhere. I actually, especially toddlers, like D. It's less threatening and it hurts less. And then the last chapter of today is pain management. Probably one of the things when I started into pediatrics about 25 years ago that I was concerned about because pain wasn't really looked at objectively. I'll give you an example now. This is back in the 80s when this happened. I had a child that had a condition where the tongue would fall to the back of the throat. And the normal routine was to sew the tongue to the cheek, to the lip, back then. They didn't do it with sedation. They took a stitch and went, and it was done. And from that moment on, I was always, no, you're not doing that. We need to make sure the child's comfort is met. Now, children, they tend to suffer from inadequately treated pain, whether it is not given on time, whether not enough was given, or they didn't supplement it with other things like distraction, ice, heat, positioning. All of those things can also help you too. we can measure pain in an infant, and we can measure pain in a nonverbal any age child adult. Okay, so one of the ones that we use for infants and nonverbal children, adults, is called the Flack scale. And if you look at the initials, F, facial expression, L, leg movement, A, activity, C, cry, and C, consolability. And there's numbers assigned to it. And it will give you a number that says, oh my goodness, they're in pain. And you would, just like if it was a faces scale. Now, Flack scale is used up to age 3. When they turn 3, it's a faces scale. You need to know the change and when we do that. Faces scales start at age 3, all right? And what's pretty neat is adults, you ask them how much pain they're in, they're going to tell you a 20. You ask a child, and they'll probably tell you an 8 because there's such honesty in them with pain scales. So, Flack, from 0 to 3. At 3, we start the faces. At age 8, we can do numeric. From 0 to 10, how much is your pain? 0's no pain. 10's the worst pain in the world. What are you? There's all sorts of pain that we have. Children are with, teething. Maybe it's sickle cell. Maybe it's, had an appendicitis. All of these things can happen. We know that chronic pain affects any age person in every manner of their life. There are different types of pain scales out there. Just being familiar with what the hospital system or you're using, that they have those things. Just become familiar with them. And know that there are cultural differences in pain. There are many patients, children, that are told by their parents, oh, you don't have pain, you're fine, suck it up, you're a big boy. Well, if they're going to have pain, please give them something for pain. I've seen this, for instance, when we want to give a little morphine for a very bad break to put on a cast. And they're saying, no, it's okay. You'll put it on, it'll be fine. I'm like, no. We need to give something, okay? It's the cultural thing sometimes. And know that kids sometimes won't tell you they're in pain because they don't want the medicine, whether it tastes bad or they don't want that pinche. No pinche, don't give me a shot. When you're giving stuff for pain, it's not just pain, okay? There's other things that we can do in order to help these children. And it's called distraction. I am the expert at distraction. I've always will have stickers in my pocket for girls and for boys. I would always maybe sometimes get some crayons out, turn on the TV, turn music on. Older kids, give them crayons, a coloring page. So many ways you can distract a child. I've done spinal taps with an iPad with a child watching something and they didn't know they were even doing a spinal tap. I mean, we can use distraction and it's great because you've calmed the child down. So everything's loose, not tense, and the procedure goes so much better. Another way we use pain management is non-nutritive sucking or a pacifier. It's been proven by Harvard as one of the research articles that I researched. It talks about pain control during a circumcision. And they were looking at a pacifier with a little sugar water on it and morphine. They found no difference between morphine and a pacifier with sugar water. My grandson that was living with me at the time, we took him in to get a circumcision because he needed one. And he did it under a pacifier with sugar water. And yeah, I heard him cry when they put him in the thing that holds him down because they have to support him. It's this thing, they strap him in, all right? And he cried for that. As soon as they took him out, the crying stopped. He never cried again. So pacifiers, you have an infant crying, pacifier is a great thing. Another thing is kangaroo care. use this a lot in the newborn ICU. You know, I've had infants sitting in warmers, intubated, premature, and they're just, they can't get comfortable and they're moving and their heart rate's up and down and they can't rest. Mommy comes in, does skin to skin kangaroo care. That child goes to sleep, heart rate, respiratory rate comes down, blood pressure comes down, and they relax. I think the pain is gone then, huh? Just by holding the child. And it's just not morphine that we give. You can use acetaminophen Tylenol. It's a great thing to do. NSAIDs cannot be used, ibuprofen, till they're 6 months old. There's something about NSAIDs and bleeding coagulopathies that it affects it. So no NSAIDs till they're 6 months old. That's the ibuprofen. Opioids can be used at birth. And there's all different sort of other anesthesias. The PCA pump, patient-controlled analgesia. Do you think that can be used in pediatrics? You can. Older children that have been instructed. And then you're going to think, wait, if they have that pump, they're going to play with it and keep pumping and pumping and pumping because it's there, right? Well, there's a lockout. You can only get a certain amount so many times, and it's a lockout. So it's very, very well protected, because I thought the same thing. Wait, they can keep punching it. It's a button and it makes a click, click. When you hear it, they're going to try to play, but usually they do really well. Other things we could do is anything to numb anything, whether it's immunizations, whether it's to use EMLA to numb the arm for blood draws. All of these things are great to use, decreases the pain. I mean, this little girl's going to get her blood drawn and she's smiling, right? And pain is everywhere in kids. I think the biggest one is ear pain. They get a lot of earaches. How do you prevent earaches in children? One of the big causes, smoke. Smoking, secondhand smoke. It's a big thing for ear infections in children. We know they're teething. We know all this other stuff can cause it. Okay. Which of the following is an important factor for consideration and understanding the pain experience in children?
Is it A?
B,
B?
they're not going to admit they have pain because they don't want a shot. They don't want to drink it. How many kids don't like their medicine? And they are not. Or they've been told, no, you're a big boy, you don't need it. So those are the reasons. It's usually they're not going to admit it. It's you looking at that kid, crumpled forehead, or you see him laying in bed and can't even move. And you're going, oh, that kid hurts. Let me get them something. All right, let's go do our first cahoots. Any questions about the first lecture? Who wants to win today? Amanda's going to win today? Courtney's going to win. I saw a smile. She told me. I'm going to give you guys a 15-minute break. come back at 9:30. It's about 13-minute break, 9:30, and we'll finish this, then we'll be done. Hey, are you ready? Anybody else coming? There you go. All right. Week 1. The leading cause of death from unintentional injuries in children is. There's one thing that's common to every single one. It's motor vehicle fatalities. Think about it. You've got infants, you have to strap them in properly. Then it gets to preschoolers, they're more mobile, they're being run over by cars. Then you have the adolescents who are now driving those cars. So motor vehicles is why it's that. Which statement is most descriptive of pediatric family-centered care? Family-centered care. So remember, family is the only constant in their life, right? And then I'll ask you, what is the family? It's whatever they say it is. The major cause of death for children older than 1 year old is? Unintentional injuries, whether it's in a car, whether it's falling off of something, out of something, it is absolutely unintentional. Didn't mean to happen, but it does. The nurse caring for the patient in pain understands that distraction. You know, you're all going to find, if you ever work pediatrics, you'll find your own way to distract the child. You know, I used to, and I was allowed to at the time, I would dress in the brightest, bright yellow, lime green. I was that one who wore this crazy stuff. And, you know, that actually helps them. It really, really does. So if it's something they can understand, it will distract them. If it's above their heads, they're not going to be distracted, so it's going to do nothing. So again, developmentally appropriate is your number one thing. Get on their level and focus it to who they are as a person. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? So 2 or more children are playing together, but there's no goal there. What is that called? And then I'll ask you one more question. What age group is that? It's associative play. So parallel play is to each other. They're not engaged together. They're separated, not playing together. Parallel, toddler. And then they become preschoolers and they can play with each other, all the same toys, but they just play. Nothing happens from it. It's just good old play. And cooperative is school age, and there is a goal. Whether they build the castle, whether they checkers, they won the game, there's 2 or more playing a game, and there is a goal in the end. Those 3 you need to remember. Which statement best describes the process of critical thinking? I remember sitting in orientation with a group on campus, you know, and the dean was talking about critical thinking. And by this, you're going to learn how to critically think. And I saw some of the students like, what does that mean? And you guys do critical thinking every day. You've already thought about, so what was for dinner? Who's going to get it? And where is it coming from, right? That's critical thinking. You needed to feed your family or yourself, and you need to find food. And you did it. It's still critical thinking. And that's as simple as it is. What is probably the single most important influence on growth at all stages of development? Most important influence on growth and development. And without that, you're not going to have good growth or good development. Nutrition, nutrition, nutrition. If they're not feeding the tank, the gas not going in the car ain't going to move on anybody. If you don't feed them proper nutrition, the brain is not going to work the way it should. You're not going to grow the way you should. Which function of play is a major component of play at all ages? What does play do? What does it develop? And it's sensorimotor activity. So what does that do? It helps understanding the senses, learning the fingers, what's the feel of sand, what's the feel of clay, right? It also has the mouth. Everything a child does goes in their mouth. How does a child explore the world? Through their mouths, especially infants. And then the motor, moving things around, playing cars, vroom, vroom. All of these things are what play is all about. How do you apply nystatin to an infant with thrush? This is one of the most common things that happen to infants. It's usually the bottle-fed one, and the bottle somehow it wasn't cleaned properly enough, and they get this white film on their tongue. And I'm telling you, this does actually hurt. Many people try to scrape it off with a tongue blade. It's not going to go that way. It is a fungus. It needs nystatin, and you take just a little Q-tip, a cotton swab, and put it on the area with the medicine. Now, an adult, how would you give nystatin? Swish and swallow, right? Or swish and spit, whatever the doctor says. But an infant, they don't know how to do that. A syringe ain't going to get it where it needs. You need to paint it where it absolutely has to go. Three children playing a board game would be an example of what? Three children playing a board game. What does that tell you? I'll tell you at school age. Cooperative play. Yes, 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 yes. Thank you. Oof, got it. The head to tail direction of growth is referred to as. Remember, take words, pull them apart. What does it mean? Which can relate the better enough, good enough. Cephalocaudal, cephalic is a head, right? Head to tail. There's another incidence where there's a little in the word. When we get to the point we're looking for ASO titers, anti-streptolicin titer, which shows strep in the body. Anti-streptolicin, ASO, is for strep. Think about that when we get up to week 5. What is the single most important factor to consider when communicating with children? So the thing we need to know about children is we don't get on their developmental level or what they can understand, they're not going to do what you say. It's better to sit the time, actually play is a way to get and understand developmental levels, and then you could get the information you need. when knowing the cognition of that child and how to approach it. What 2-year-old child pain assessment tool should the nurse use? 2-year-old. What pain scale is that one? We have FLAC, we have FACES, we have numeric that I talked about. And then another thing I'll tell you, if I've never said the word, you've never seen the word before, it's not going to be an answer to any exam. So 2 is less than 3. They can't tell you how they hurt. It's the FLAC. Faces, legs, activity, crying, consolability. Absolutely. And what else is FLAC used for? Non-verbal children, even adults. They can show with their body how they feel. At 6 months, an infant's birth weight should what? And this is something you need to know to see if they're getting proper nutrition, right? Let's say you had a child who's just not rolling over at 6 months yet, and you're wondering what's going on. Well, let's look at the weight. Have they gained what they should gain? And if not, they're not getting the nutrition they need. You're not filling the brain. It's going to see the answer. So at 6 months, it doubles. At 1 year, it triples. So if you're born at 7 pounds, 6 months, you're 14, and at 1 year, you're 21. Why do you need to know that? Because you need to evaluate these children, and you have to know, did they get the proper nutrition? So they should be on that level, or was it a problem with nutrition? The first expected fine motor developmental milestones for an infant begins with. So fine motor is F fingers, anything with fingers. What's the first one they do? You're going to see fine motor skills and gross motor skills. And you need to read these questions carefully when you see them. When it's fine, it's only about fingers, okay? So a palmar grasp, that reflex is it happens and they didn't know. You put your finger there and oh, they grabbed it and didn't even know it happened. That is absolutely the first. Then it goes to a voluntary, they grab it. Then it goes into this pincer grasp, which is like, it'll end up like this, but it starts out with a smush to the face. And then it's that fine pincer grasp. Then it goes to putting objects in a container at 11 months and building a block of 2, 1-year-old, 12 months. And it's in the book written that way too. An 8-month-old infant should be expected to perform which fine motor skills? So if we started out with a reflex palmar grasp, then you had to get it into a voluntary. Where do you think we're going to be? Very good. They're going to grab it. They can do that. And it also starts out with that beginning of putting those little Cheerios on the high chair, and they take their hands and smush it first in that, pincer grasp. And then all of a sudden they pick it up one at a time, and one at a time really neatly they end up doing. That's the evolution of that pincer grasp. Very good. The natural physical developmental sequence that most children follow is so first thing that they move is their head. Because, at first they don't move anything. There's no control. And by 3 months, they're going to lift their head. By 6 months, they're rolling from the front to the back and back to the front. I'm going to ask you, why do you need to know and why should you teach a parent that? It's all about safety, isn't it? If they don't strap the child to a changing table or in a bouncy seat or whatnot, they could roll off, they could fall down, they could hurt themselves. So understanding that they're rolling by 6 months is will prevent injuries. I have a brand new grandson who just is 5 months old now, and he hasn't started completely doing it yet. And every time my daughter walks away from him, I'm like, excuse me, he's going to roll. Could you strap him in or keep your hand on him? She says, Mom, you're paranoid. I said, yes, I am. He's my grandson. Take care of him. I'm teasing. She's a great mother. Which behavior indicates that an infant has developed object permanence? We're going to go into this more next week, but this is the thing that develops a lot of muscle control with your infants. That is, here's your little stuffy animal you like. I hit it. Now I'm going to try to wiggle and wiggle on tummy time to find it. Because why? Once I see it, even though it's hidden, I know it's here somewhere and I'm going to find it. That is object permanence. In general, an infant should triple their birth weight. What age? So by 1 year old, they should triple it. By 6 months, they should double it. And by 2.5, they quadruple it. Do you see how quickly it slows down? Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. You've got the most scared group of kids, ages 1 to 3, toddlers. They're the hardest group to have you trust them. They don't want to trust you. Again, basing the examination based on child's developmental age. Now, if the parents are there, it could be good or not. But the most important is your patient, your client, your child. We need to base it on them. How can they tolerate it the best? Is part of it having the parents there? Okay. Or is it they need their blankie to do it, or their pacifier, or base it on their age? According to Piaget, toddlers are in the, this is thinking, all right? And you don't know this one yet. I'm mentioning it because it's my toddlers. They are all about me, I, nobody else. It's about me. And what everybody else is trying to do is to protect them. They're trying to walk and you're trying to make them not fall. And it's called sensorimotor, right? These children do what? So they've learned how to touch. They've learned to put it in their mouth. They're learning how to walk. All of these things are Piaget learning how to go forward. They're building upon it again. Which intervention helps a hospitalized toddler feel a sense of control? Again, toddlers, it's a rough group, but they're my favorite. When you put a child on the same routine as home, they just feel a sense of calm. You're not going to give a bath time in the morning when it's always been at nighttime, things like that. Also, knowing that they need their blankie and a special pillow to take a nap. All of those things, all those routines can help us as nurses, have this child not to be as upset because they do not like to be out of their little own world of what they know. All children reach developmental milestones at the same age. My kid walks at 12 months, yours walks at 12 months. Absolutely not. Everyone is different and unique. And then you're going to say, well, if my son at 8 months was walking and my daughter is now 10 months is not walking, they're going to look and say, but oh my goodness, something's wrong with her. And then all of a sudden she's running before she even does 2 steps. And then you go, okay, now they're ahead. The thing is, parents do take two children and they do compare them all the time, and they can't because we're all special and unique, and we all, go forward in the developmental level milestones differently. Immunizations for a 4-month-old infant. What action should the nurse take to provide traumatic care? Remember, everything we do is to try to have the least amount of pain. So this is the child that you are going to give them that pacifier, aren't you? This is what gives them comfort. They're sucking on their little pacifier and they're really happy, and they're really not going to feel as much the pain of the injection. We don't just do a Z-Track. A Z-Track doesn't decrease pain. All it does is lock and load the medicine inside the thigh, if that's where we're giving it in the vastus lataris, right? But it has nothing to do with pain control. What else can I do for pain control for these children? Maybe ice it first. There's things called buzzy bees. Maybe it's, some distraction by a toy and squeaky toy as we give it. These are all distractions we can do, but the pacifier with sugar water is the best. Which of the following immunizations is administered to a newborn? So the first immunization that is given, usually at the hospital before discharge, is hepatitis B. Sometimes it isn't. It's usually insurance, something that goes on, but it's always given then at the 2-week mark when you go in for the checkup after they are born, okay? Now, you're going to notice as you go through the infant chapter, there are so many immunizations. What do you need to know and how you're going to remember them all? I will be giving you those tricks of those things that you're going to see again and again. I still go and I look at the chart to see some of them when they're given, and that's okay, as long as you're checking and giving it properly. The normal heart rate for an infant is. Normal heart rate for an infant is 140 to 160. There's one word I didn't describe to you that I am now, because you might see that. There's a difference between a neonate and an infant. A neonate is a baby infant in the first 28 days of life. On day number 29, they are called an infant, okay? Just to let you know if you see the differences there. What is the preferred site to give an injection to an infant? And then if you're looking at that picture, tell me what's wrong with that delivery of that medicine. That is a big child. That child needs those hands restrained for protection, for safety. And it is the vastus lataris. Deltoid is used when they're older. We don't give the injection to them in the arms yet, because remember, 2, 4, 6 months, there's like 4 different immunizations they get. It's just way too much. Even putting 2 and 2 on each side, it's too much in the arms. The death of an infant under 1 year old with no known cause is. And then we're going to be studying what are the risk factors of infants that get this. It's called sudden infant death syndrome. Also, this is why today there has been so much research on it. I know when I started at a children's hospital here in Miami, they have been studying SIDS death, and what they promote is something called back to sleep. And they say that all children should be placed on their back, and we have found through research, I'm talking 20 years of research now, whereas these children, there was less deaths when they were put to sleep on their back. It used to be on the side or their tummies or side on their back. And they found out even on their side, they were inhaling their own carbon dioxide. So only on their back. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why do you think that's going on? So when we're talking about culture and we're talking about differences, I've come from a small town and I don't know a lot of, different cultures. So I have always gone up to them and asked. I mean, in this case, if this mother is not going to be looking at you with her eyes, because looking at your eyes is a lack of, it's disrespect. So not doing that is showing you that she's respecting you. I mean, there's many cultures and many different things. I remember one Saturday morning, I was in triage, and this boy came in and he had a broken arm. He was sent in from Miami Beach for us to put a cast on from one of the hospitals. And the little boy's shoes were untied. And I said to the dad, "Oh, be careful, the shoes are loose." And he said, "I can't do it." And I said, the other nurse was in the room and she happened to be Jewish. And she said, there are certain types of Jewish people that cannot turn light switches off or on or do shut to tie the shoelaces. And it's something that I just had to learn. So if you don't know something, ask, because this one happened to tell me. I'm like, okay, I'll tie it for you. Come here. And I did it. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is he saying that? One of the things, again, culture, this one is it's come and believe it. I've done something bad, so I'm going to be punished. And you're going to see as we start studying school age children, even preschoolers, these children also feel that, they fell down and they got a boo-boo on their knee because they hit their sister yesterday. They're being punished for being bad. I mean, very, very common, any culture, but just be aware of it. Which term refers to a time in an individual's life where he or she is more susceptible to positive or negative influences. If you're more susceptible, it's a sensitive place where changes can happen easier. What is characteristic of the pre-operational stage of cognitive development? Well, again, this is one of those words. I'm bringing it up here as you do your readings for next week. Pre-operational is ages 2 to 7. And how do these children think? Cognitive, how do they think? And at that age, they have to sometimes see it before they can do what you're asking them to do. And that is called concrete. And you're saying, how do you remember this concrete? Thinking is concrete. And what does it mean? Well, concrete, you can touch and feel and smell it, right? Which means something you've seen before, touched before, did before, you can do again. But you have to see it first, right? That's concrete. When we start talking about formal operations, which is the older child, adolescents, they can pull it out of their head and do it. They don't need to be shown. So this is, again, Piaget is the way that they're thinking. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What did I tell you about Kohlberg? We have Freud with sexual, Erikson, which is about people. We're about Piaget, the way we think, and we're about Kohlberg, and we're talking about right and wrong and a consequence for each, morals. Okay, those are the 4 ones that you need to know. Let's see how we did. Number 3, Cargan, good job. Number 2, Mama Bear. I'm called Mama Bear, sorry. I'm teasing. Number 1, Diana. Ching, good job, guys. Number 4, Jamin, and yeah, night. I get you. So I'm going to let you go a little bit early today because I'm done. I'm not holding you over. If I can, I will. If I can, I won't. Any questions, any comments, any concerns you need, let me know. Also, if you do not know dosage calculation, I'm actually very good at it. I teach it very simple. And if you need help, I can help you. Does anybody here need help with dosage calc? I will be sending information. You all can look at it, okay? I'm going to send you probably the most comprehensive of all my recordings. It starts with rounding all the way up to mic per kilo per minute. So it gives you everything very clear. I'll send also the worksheets that go with that for you. Now, after that, if you still, I'm not getting it, I only need 15 minutes with you. I will never keep you for an hour if you come to me for tutoring. I can come today, I've got 15 minutes. Okay, I'll work in your 15 minutes. I will respect your time because I know how busy you are, okay? So I'll be posting that today with tonight's recording. And of course, the PowerPoint, I always reattach it to it because somebody's always looking for it. Start thinking about your pediatric assessments, seeing what you want to do. And then when you want, start sending them in. Actually, it's a great time to start before you start getting crazy with all the other things in, all the classes. So everybody, good night, guys.
Good night.
Pleasant dreams.
Professor. Thank you.
Thank you.
Thank you.
Thank you.